Mitraclip has been the focus of most of the conversation around transcatheter mitral valve intervention. In this country, it's only recently been commissioned for primary degenerative MR. Where do you see the array of repair techniques evolving? Mitraclip obviously has 100,000 plus worldwide patient experience. There are other repair techniques available which sort of duplicate surgical approaches. Do you see a role for them, or do you think Mitraclip is so far ahead it's going to be a real challenge?
Well, I think I'm glad you brought out that point. Very often Mitraclip is used in the same sentence as cord repair techniques and transcatheter mitral valve replacement, and they shouldn't be categorized together simply because the experience with Mitraclip is now so vast, well over 100,000 cases and well under 1,000 cases for mitral valve replacement. So it's really important to remember that. I suspect that we will need to use a number of technologies to treat the variety of patients we have with the variety of anatomy that we have. Broadly speaking, the technologies we have available to us are leaflet repair, annuloplasty, which can be percutaneous, and cord repair or replacement, and obviously mitral valve replacement. I suspect the majority of patients will end up being suitable for mitral valve repair using one of the leaflet repair techniques, of which Mitraclip is one.
Do you think combination techniques are we're going to see more in terms of repair techniques to get better outcomes, or do you think that's going to add to complexity?
I think we may do, but what I have noticed with the XTR, the Mitraclip with the longer clip arms, is I suspect it has a small amount of annuloplasty function as well. If you get a large amount of leaflet in your grasp, I think you probably do a little bit of annuloplasty as well. The other thing I think to remember is the dynamic nature of mitral regurgitation, and if you treat mitral regurgitation, the left ventricular dilatation is likely to reduce. So I would personally suggest that mitral repair with a leaflet repair probably is the first line for most people, and then if they have residual issues later or mitral regurgitation that develops later, then that can be treated either using a further leaflet repair or the other technologies that are available. Some are available now and some are available in the near future.
And I guess there's a lot of work still in terms of innovation that we're going to see. So we're still relatively early in this field, aren't we? You mentioned the dynamic nature of mitral regurgitation, and that brings us to that group of secondary MR patients, which is really much more challenging, both in terms of assessment, and we know we have very sort of imperfect parameters in terms of assessing severity of mitral regurgitation or indeed left ventricular function. A lot of excitement around MitraFrance and COAPT trials and the positive results of COAPT, which is really a game changer, would you agree, in terms of our understanding of mitral regurgitation in LV impairment, and we've still been uncertain about whether it's a driver or a bystander. Do you think COAPT trial really does seal that question for us and paves the way now for a definite role for mitral valve intervention?
Well, I think we were all hoping for the COAPT result. I think we were surprised by the strength of the result. We all remember what it was like being in the room when those results were released. I don't think we were ever expecting a mortality benefit. It's important to remember that COAPT showed a mortality benefit with a number needed to treat of 6 over 24 months. There are very few heart failure therapies, whether interventional or drug-related, that have a number needed to treat as low as that. So I think that was very encouraging, but I think also what we learned from COAPT and MitraFrance is that this is quite a heterogeneous group of people. Having severe LV impairment and some mitral regurgitation, there's quite a wide range of patients who fulfill those criteria. I think what is important in assessing them before going any further is that they are medically optimized. We've all looked after patients who have severe mitral regurgitation who then are medically optimized and they no longer have severe mitral regurgitation, and that should happen well before any discussions about any interventional therapies. I think the other important point that was identified by MitraFrance and COAPT is the safety of the procedure. As interventional cardiologists, and particularly structural interventionists, we're used to doing TAVI, which is an excellent procedure, but it has a small risk of very serious complications. And that is not something that we see in the Mitraclip procedure. Patients generally do very well in the procedure. There are no dramatic moments during it. The only thing that happens is that the patient's blood pressure goes up a little bit as you close the clip, and that's it. And the vast majority can go home the following day. So I think the important thing for these pretty sick patients, the patients with secondary mitral regurgitation, is that mitral intervention using leaflet repair with a Mitraclip device is very unlikely to do harm, and it's very unlikely to make things worse. And that is very important when you're talking about patients with the kind of risk that they would have for any other kind of intervention.
Yeah. And I guess that idea of proportionate and disproportionate MR as a new concept has emerged. And the idea that there's this therapeutic window where you can look at LV function and mitral regurgitation severity. From an echo perspective, can that be encapsulated as in terms of some specific parameters to look at which might indicate benefit? Because it's still hard to disentangle which patients will respond.
I think we've been traditionally taught that with mitral regurgitation, the parameters that we use are essentially looking at the regurgitant orifice morphology. And all the calculations that we do for all these quantitative markers are actually focused around assuming that the regurgitant orifice is circular. And what we know, particularly with secondary MR, that's absolutely not the case. It's the opposite. It's an elliptical orifice. And so the way we calculate our effective regurgitant orifice area, which is used using colour flow Doppler in this PISA technique, essentially underestimates. So we systematically have underestimated the severity of mitral regurgitation. And the first glimpse that we had of what impact that was having was the Mayo Clinic published a very nice series of patients looking at their MR population and found that those that had a cutoff of 20 millimetres squared of their EROA, essentially they behaved like they had severe mitral regurgitation in terms of their outcomes. So that got everyone thinking. And in fact, with the advent of 3D imaging and 3D colour, we then realised that actually when you look at the orifice in detail, it's often not circular, even with the primary regurgitation group. So the newer techniques now focus on looking at that vena contractor. So that's the portion of the jet where the flow becomes laminar and goes through the orifice. And that essentially, if you can quantify that and measure a diameter, what you're doing is looking at the regurgitant orifice. So it's a very nice, simple way of assessing it. So what we've realised is actually we should look at it in orthogonal views, so 90-degree views. So we used 3D imaging formats like X-plane, biplane imaging, and that allows us to align ourselves up in a short axis, long axis view. So taking that further, with actual 3D colour, what we can now do is not only look at the vena contractor in terms of a dimension, diameter, linear measurement, we can look at it in terms of an area. So because we can drill down right to the level of the orifice, we're now realising that what we thought was moderate is actually quite severe. And so that's really shifted how we've understood mitral regurgitation. And now putting that in the backdrop of mitral FR and coapt, and the fact that this is probably a spectrum of disease, and that we're somewhere along that natural history, and probably looking at mitral FR with bigger ventricles, larger volumes, less regurgitation, in fact, in terms of the ERA, those patients were probably ones that had primarily ventricular disease, with perhaps a secondary event of mitral regurgitation, whereas the coapt group were less. The ventricles were smaller, the volumes were smaller, the ejection fraction was slightly better, and the regurgitant orifice was higher. So that suggested that actually the MR, perhaps a secondary event of that ventricle disease, ended up being actually as important as the ventricle. So reducing the MR in that setting has made a difference. Whether that represents two different disease entities or a spectrum, we're not clear yet. And that's where more information is needed. And that's where your point that actually getting better at quantifying the regurgitation becomes key. And then, so I would emphasise the 3D colour formats and vena contractor area as a way forwards in helping us understand
and looking at LV volumes in conjunction with that.
Absolutely.
As well.
And part of that actually is the workup for these patients. So actually not just that, but you can look at volumes, you can use MR for various aspects, but also functional testing. So looking at contractile reserve, looking at pulmonary artery pressures, looking at symptoms in the context of MR becoming more severe during exercise. All these parameters actually help decide whether relieving that mitral regurgitation is actually going to make a difference to that patient.
So from a practical perspective, we've, I guess one could argue that the COAP data was so profound that Mitraclip might well be a new comparator in terms of heart failure intervention studies. But equally, we have heart failure drug therapies that are developing. In terms of how you select patients, because that is key to how good an outcome we get from our interventions, how have you set up your heart valve teams and patient pathways? Because these, I think what's clear is that the degenerative MR population and the functional MR population are very different. So do you have very distinct pathways? And then they come to a common mitral valve team. Where do the heart failure experts fit into that process?
I think we're still learning. I think that's the first point. And I think the other thing to say about the COAPS data particularly is that many of the centres who are recruiting to the COAP trial were transplant centres. So they have a very large amount of resource to very advanced heart failure care. In the UK, I think currently most patients are seen by the interventionalist who's likely to do the procedure rather than separating them out into degenerative versus functional mitral regurgitation. Certainly that's the case in my centre, so patients of either etiology are referred to me. Who they're referred from is different, so the heart failure people tend to refer the secondary mitral regurgitation patients. What I've learnt about managing these patients is, although the procedure for most patients is fairly straightforward and it's extremely well tolerated, that does not mean that they take very little looking after. They need to be monitored pretty carefully, particularly the secondary mitral regurgitation patients. They need to be optimised before and particularly afterwards, because there are fluid shifts related to this procedure which are not necessarily predictable. So they do need to be watched quite closely afterwards. Generally not in hospital, but they do need to be watched quite closely. I think probably the secondary mitral regurgitation patients would benefit from being looked after by heart failure specialists afterwards, probably more than interventionists, but currently post-procedurally they're looked after by us.
Is that similar to your...
Yeah, so I guess with us, it's you could have patients from all sorts of places, and that does make it more challenging. And what we've worked at is identifying key individuals within a very broad group who are aware of where these kind of transcatheter therapies fit in, and then I bring the patients to an MDT. So it could be a surgical referral. Surgeon sees a patient, decides they're too high risk for surgery, various comorbidities, and then they bring them to the mitral MDT, or in our case it was a valve MDT, where we would then discuss the patient with a wider group. But as Sam has said, actually very importantly, particularly with the functional and the secondary MRs, we have to make sure we include the heart failure team. The EP team become important too, because some of these patients benefit from CRT, and that's our steps. Step is optimise your medical therapy, still symptomatic. At the same time, you look at their ECG and work out whether you think you're going to help them from a perspective of resynchronizing their ventricle. Then you need to give a bit of lag time. You need to give 3 to 6 months of them to allow the ventricle to remodel, both in terms of medical therapy and in terms of your CRT. And at that stage, if the patient is clearly symptomatic, then that's when we start having the discussion, and that's where the patient then will come to the MDT. But I also wanted to highlight, because this is important as part of this wider group, is that it involves multiple people with multiple skill sets, and who we mustn't forget in terms of the infrastructure and making sure the patient gets the best value in terms of their care is the allied healthcare specialists. So the nursing team, so they're really important, the specialist nurses who support the clinics, who actually pick up all the pieces around us when we're seeing the patients in terms of, their dental checks, making sure their anticoagulation issues are thought, any questions they have on the procedures and the kind of care they may need afterwards. And then also in terms of the imaging, because a lot of this is echo heavy, the physiology team are very important in terms of the echo department and having those higher skill sets, so that you can then essentially be a team that everywhere we're all able to deliver that kind of high-level understanding that is needed to manage these patients.
No, absolutely. I think all our teams have sort of recognised their critical members, isn't it, if we're going to deliver these therapies effectively.